Hi guys, welcome to New Age. Thanks for visiting our website. There are different ways as a plastic surgeon I can increase the size of the breast. I can do this with fat grafting, I can do this with breast lifting, and the most common and straightforward way to do this is with breast augmentation using implants. This is one of the oldest operations that we do in cosmetic surgery. Breast implants were invented in the 1960s. They're still a very popular surgery to this day because it's a very straightforward procedure with minimal risks in the vast majority of patients. This is an operation where there's lots of different choices that patients need to make about what their surgery is going to entail. And as a plastic surgeon, my job is to give people as much information as I can about what those options are. The first thing when I talk to a patient about this operation is what incision are we going to use to put the implants in? So there's different options. By far the most common one that I use is something called an IMF incision or an inframammary fold or crease incision. So in this case, I'm making an incision in the crease of the breast, and I'm doing that to get access to the area where the implant is going to go eventually. People like this because you can hide it very easily. Another option is to go in through the bottom of the areola, and so you would make an incision from basically the 3 o'clock position to the 9 o'clock position. Then you actually cut through the breast tissue, and then you get to the area that you're going to eventually put the implant in. I don't like to do this option that often. The main reason is that the IMF incisions always heal beautifully. There is a chance if you're putting a scar right on the front of the breast that if it doesn't heal well, you can have an ugly scar. I've never seen that, but it is a possibility. There's also an option of putting the breast implants in through the armpit or even through the belly button. I've never done either. These were more commonly done back when people were using saline implants, and now most people just use silicone. The reason you could do this with saline implants is that you'd be able to insert a empty breast implant, and it's rolled up kind of like a cigarette, and then you make a little tunnel and you pass the implant through, and once it's in the pocket or the space that it's going to be in, then you inflate it. People don't use saline that often because it's a very fake look and feel. You can have problems with rippling. They feel springy, kind of like a water balloon. And over time, you can also get something called a water hammer effect, whereas people are walking, it's basically a bag of salt water, and the water moves up and down, and over time, that can actually lower the implant or push it off to the side. So most often, I use a IMF crease incision. People often ask, what is better, going subglandular or submuscular with the breast implant? And so this basically means, where is the implant going to sit? Is it going to sit between the pec muscle, which is here, and the breast? Or is it going to sit underneath the pec muscle? There is no way to wrap an implant completely in muscle. So the way that we put a breast implant in under the muscle is we cut the bottom of the muscle, and we cut part of the attachment to the sternum, and the muscle actually raises a little bit. Some people will call this a dual plane procedure. There's different types of dual plane procedures depending on the level that you raise the muscle. This is also something called window shading. There's advantages and disadvantages to both. So typical advantages to going underneath the muscle is that if you're someone who doesn't have a lot of tissue at the top, if you're going to go for a subglandular augmentation, what you're going to see is skin and ribs and then an implant, and that's a very artificial look. And so in someone like that, what we want is we want to use that muscle to cover the very top of the implant, so it's a more natural transition. However, there are drawbacks to going underneath the muscle. The main one that I see is something called an animation deformity. Every single person who has a dual plane or a submuscular augmentation, they will get something called animation, where when they flex their pec muscles, the implants are going to move from side to side. This normally isn't anything that bothers people, but it is an unnatural movement. So the way to avoid that is to go subglandular. People did think at one point that doing a subglandular augmentation had a higher chance of a complication called capsular contracture. This is the most common complication a patient will have or is likely to encounter after surgery. This is where your body is building up an excessive amount of scar tissue around the implant. The studies that showed that submuscular augmentation was better for capsular contracture, they were fairly older studies. A lot of them were done in the early 90s, and the operation is done much differently now. I personally do not believe that there's a difference in capsular contracture rates between subglandular or submuscular. In terms of the implant size, this is not a one-size-fits-all operation. So we can't just put any size of breast implant into any patient. We take precise measurements of a patient's existing anatomy. We measure out the width of the breast, that's actually called the foot plate, and that will give us a range of safe implant sizes that we can use. If you go outside that range, you are going to increase your complication rate. The implants all cost the same. Whatever plastic surgeon you see, they have no incentive to put in something smaller than what you want, but they do have an incentive to try to do the operation as safe as possible while still providing an excellent cosmetic result. I often find it helpful when patients come in if they can bring photos of the type of result that they want. Believe me, there are times when people tell me they want something and they show me a picture and it's totally different. These are some of the things that we can talk about, if you're interested in coming in for a consultation at New Age. This operation requires a general anesthetic, meaning you're fully put to sleep with an anesthesiologist looking after you. It takes me about an hour. When patients wake up, there's a bandage on their chest. They go home with this bandage. In my practice, it stays on for a week. Most people typically take about a week off of work. So unless someone has a very physically demanding job, a week is really kind of all you need. The recovery process should not be a particularly painful one. Most people need prescription painkillers for maybe a day. And then after that, it's really just, we want patients to focus on healing, recovering, taking time for themselves. I don't want people trying to be, to go back to their normal routine too quickly, because that's the kind of thing that can lead to a complication. At 4 weeks after surgery, patients can do literally whatever they want in most cases. So if you're interested in learning more or scheduling consultation, you can scroll down to the bottom of the page where you can enter your information and be able to book a consult with me at New Age.